Right, so today's talk is about cancer. And the things we're going to be covering are first of how benign and malignant tumors are different. Then we're going to talk quite a lot about cancer biology, and how tumors develop. And later on, some of that's going to be useful when we talk about some of the cancer managements as well. And we are going to be talking about some specific viruses causing cancer as well. You may have already noticed the QR code on the right-hand side. So if you want to scan it, there's going to be not an awful lot, but a few Menti questions just to keep it a little bit more interactive as we go. So I'm just going to give you a few seconds to scan it, and then we can get started. Obviously, I can get back to the QR code later if somebody misses it. All right. So let's get going. So first of benign versus malignant tumors, you have probably heard about these already. So you probably roughly know that benign tumors are those relatively harmless ones, and malignants are those that can be pretty harmful. And the main reason for it um, is because the benign tumors are relatively slow growing and mainly they are non-invasive. So they usually stay where they are. They can just be there for quite a long time. It's something like warts, they can be there pretty much for the entire life, and stay the same size and do nothing at all, no harm at all. They also usually tend to be encapsulated, which is also associated with this property of not really spreading as much. And they tend to be quite well differentiated versus the malignant tumors. They grow relatively fast, and very importantly, that they are invasive and metastatic. So just a quick note here, they are actually slightly different terms. So while invasion can just be within the local area, metastases then mean spreading to remote sites in the body. Quite often they are not encapsulated. And in terms of their differentiation, some people think that they are always not well differentiated. And whilst this is often the case, and this is often associated with a worse prognosis for the tumors, it's not always true. And some of them can actually be relatively well differentiated and still pretty harmful. So that is relatively variable for malignant tumors. Um, now, let me. Oh yeah, this is actually time for the first Menti question. So let me see if I can get Menti working. Are people seeing the first question yet or not yet? Seeing the first question. Okay, so let me see. Oh, people have replied to the first one already. And yeah, it's absolutely correct. So everybody's got it right so far that the name of a malignant tumor of the cartilage is the chondrosarcoma. So based on that, we're going to demonstrate some of the principles of the nomenclature. So you usually have this ending, which is either oma or carcinoma or sarcoma, depending on whether it's benign or malignant. And there are variable prefixes based on the tissue of origin. So as you can see for epithelium, it would be papilloma or squamous cell carcinoma. This is why you can see loads of squamous cell carcinomas in different parts of the body. So it can be places like the esophagus, the skin, it can be the kidneys, it can be quite a lot of different places. With smooth muscle, it's relatively straightforward. It's either leiomyoma or leiomyosarcoma. Then with glands, it's adenoma or adenocarcinoma. Skeletal muscle is different for smooth muscle, so careful about that. Um, and the fatty tissue, it's either lipoma or liposarcoma. Um, and um, I think I have one more question on Menti actually. So if I just move it, I've already given you a hint on the previous slide, but if people wanna answer the question, what type of tumor the uterine fibroids are based on what tissue they think they arise from. Not sure if people are seeing the second question yet. Are people seeing the second question? No. Okay. Let me see where the problem is. Still nothing? Probably not, because I'm sure people would be answering. All right, I don't want to spend an awful lot of time on this, and I'm not sure why this is not happening. So let me just give it. Oh yeah, it's happening now. People have started responding. Lovely. So we've got some leiomyomas, we've got some rhabdomyomas, but the majority of people are correct. So we actually have 6 answers saying leiomyoma now. And that is absolutely correct, because the fibroids in the uterus arise from the myometrium, which is the smooth muscle in the uterus. Rhabdomyoma would be if it were striated muscle, but then unfortunately it seems that it's pretty hard to control the smooth muscle. Sorry, to control the muscle of the uterus purely by will. So it means it's a smooth muscle, and it would be a leiomyoma. Lovely. So let's move on from the nomenclature, which is unfortunately very dry and boring, but it's useful to know for future purposes. And let's move on to something more interesting, which is the metastatic spread. So the metastatic spread can be either direct or embolic, and direct, that means into the local structures. This usually involves breaking the basement membrane and spreading into the tissues around, and embolic would be into remote sites via either the lymphatic tubes or via the blood. And you can see a little bit of a diagram here, which basically shows the stages, where the first one of the stages is a transition of the cells from epithelial cells to mesenchymal, so that they gain the properties where they can more easily invade through the tissues. Then they start circulating in the blood. And one of the important properties that are actually necessary for tumor cells is to be able to survive in the circulation, not just get there. And many tumor cells are not able to survive in the circulation, which is why it actually takes some time for the majority of tumors to metastasize, because it's only one out of many cells that are able to fulfill these criteria. And then the next sort of point on the pathway is the seed and soil model, basically, which means the cells which have been spreading through the circulation or the lymphatics, just homing to one of the tissues, penetrating through the endothelium of the vessel, and finding their spot in the surrounding tissue and starting to proliferate, which again is a bit of a limiting step for some of the cells, and again slows down the rate at which tumors can metastasize in the first place. It's relatively interesting. We currently have relatively little information about what predefines the tissues where tumors are able to home. It seems to be related to a large extent to some of the molecules on the endothelium, such as some integrins, etc. But it's relatively surprisingly poorly understood why, for example, some tumors are much more likely to metastasize in the liver, some much more in the brain, and that sort of thing. So that's still subject to research if anybody's interested to research a bit more on that. All right. But yeah, overall, forgot to mention, but overall, the preferred sites for homing of the tumors are usually bone, liver, and the lungs. So just to move on to the next one, I've included a few experiments that I think hopefully you would be able to use in your essays if you want to include some experimental evidence. And this one I think is quite interesting, because it gives you some evidence for involvement of not only the tumor cells themselves, but also of the microenvironment around the tumor cells. So it's been investigated quite extensively what actually forms the microenvironment of the tumors now. And it's known that some of the components are matrix metalloproteases, so-called MMPs. Then the tumor necrosis factor alpha, which is one of the cytokines, and also some macrophages. And quite interestingly, it's been discovered that inhibiting both the MMP and TNF alpha can relatively significantly reduce the invasiveness of some of the cancers. This was particularly done on breast cancer. It was done in vitro, so obviously it's not it's not, you know, evidence set in stone for any of the in vivo experiments later on, but there will definitely be more evidence now on it because this is from 2004. But in vitro, it was really reliable evidence that if you inhibit the MMPs and the TNF alpha, the tumor is not as invasive. And quite interestingly, it was also shown that the breast cancer cells alone and macrophages alone release relatively low amounts of the MMP, but when they are co-cultured together, the MMP supernates and they collect increases really quite significantly, which is what you can see on the right-hand side. For the first two names, the MCF7 and the SKBR3, they are both just names of cell lines of breast cancer. The HTERD, that is a cell line for normal epithelial breast cells, so non-malignant. And MAC, as you could probably understand, are macrophages alone. So you've got the author and the paper basically referred to there, so you can have a look at it later on as well. All right, so now let's move on to the cell cycle and let's talk a little bit more about what's happening in the cancer cells themselves and how some of these things can go wrong to promote the uncontrolled proliferation of the cancer cells. So as you can see, the cell cycle, you've probably seen it many times already. You've probably seen it. I'm not sure if the majority of people here are second years. I would probably think so. So if yes, you will probably have seen it in first year a lot. And you probably know that you've got the interphase, which is the where the cell is just basically growing and duplicating some of its organelles and also replicating the DNA, and the M phase where the actual DNA separation and cell division happens. And this is relatively important to know because we will be talking about some checkpoints of these phases which can go wrong on the next slide. And this is right here basically. So you can see there's a few checkpoints. There's the G1 checkpoint for the G1 phase and G2 checkpoint for the G2 phase. The G1 checkpoint, it tends to be said that is the major checkpoint of the cell cycle. And this is the point at which the cell can decide based on the factors coming in from the surroundings and based on some signaling molecules from the inside as well. It can decide whether it actually wants to go on, continue and go ahead with the DNA replication and then the division, or whether it wants to stay in a resting state, which would be called G0. And this is regulated largely by growth factors, and we have discovered that growth factors are involved in a number of cancers. And uncontrolled signaling with growth factors and uncontrolled perception of growth factor signals by the receptors, which can be expressed in the tumor cells in much larger amounts than they would normally be, can be one of the major problems causing the cells to proliferate. So you can see the growth factors here. There's really quite a variety of them, and they depend on the organ. And this is basically just to illustrate some of the complex signaling cascades. It's not something that you should be learning molecular by molecular. But if you do have specific interest in some of these, and if you do want to write an essay on one of the specific pathways, it can be very interesting because a number of these signaling molecules which are involved in regulation of the cell cycle have already become quite important targets of cancer therapy. So it's quite interesting to explore them from that point of view. All right, so oncogenes in general, they may be related to the growth factors and growth factor receptors that we talked about. They can be other things as well, but in general, oncogenes are genes which promote the cell cycling. And in general, they are those that, when mutated, promote the cell uncontrolled proliferation. But quite interestingly, it has been shown that a single oncogenic mutation definitely is not alone to cause cancer. And one of the examples would be RAS GTPase. It stimulates proliferation and growth, and it's mutated in about 30% human tumors. By the way, Cosmic is this website where you can check the mutation rates of specific molecules, receptors, etc., in different types of tumors. But to get back to RAS-GTPase, it has been discovered that when you introduce it into normal cells, they actually do not go into the uncontrolled proliferation, and they arrest in the G0 non-proliferative phase, and that's largely due to activation of the tumor suppressor gene p53. So this very much demonstrates that, at least in the case of RAS-GTPase, just this single mutation is not sufficient to flip the cells over into cancerous growth. And this is why, again, cancer doesn't develop in all people at very young ages, because we would all probably have some mutations that would promote cancer growth, but it's just about the accumulation of these to actually start developing cancer. And tumor suppressor genes, on the other hand, I have already mentioned one, which is p53. There's many more of them. One of them is BRCA in the breast cancer, again, quite well known. One other one would be retinoblastoma, and in general, they are sort of the reverse of the oncogenes in the sense that they promote DNA repair and stimulate control cell death. They stimulate apoptosis. So they usually block oncogenes from as I mentioned, sort of going into from having the cells going into cancerous growth by basically causing apoptosis if it looks like the cell is too ill to grow normally. And some evidence for the tumor suppressor genes here. So it was shown that when tumor cells and normal cells are fused, the fused cells lose the tumor-forming properties, and that's because of the protection with the tumor suppressor genes. And then when you start reculturing these cells many times, you again start losing the normal chromosomes, and the tumorigenicity appears again because the mutations start accumulating again. And in this sense, you could basically say that cancer is a recessive trait that you need to have a specific mutation or a combination of mutations on both of the chromosomes in a cell. And then obviously in cancer, you can have more than just a pair of each of the chromosomes. You can have much more of them. But basically, you need to have this problem occurring in both or the majority of these chromosomes to actually have all the trouble. And this, again, is some evidence for you to potentially be able to include in essays. And it's about a combination of the BRAF oncogene and the tumor suppressor gene p53. And it was shown, this is from 2005, it was shown that this BRAF V600E, which is a mutant version of the BRAF oncogene, can be transfected into zebrafish. And when you do it, the mutant zebrafish develop these ectopic melanocyte patches, as you can see on the right-hand side. So the bottom part in B shows the melanocyte patches, but themselves, they are not cancerous yet. But if you combine it with deficiency of p53 in the same zebrafish, the zebrafish tend to develop melanocyte lesions, which almost immediately turn into invasive melanomas. So again, it shows that a combination of factors is needed for the cancer to develop, not just one of the problems. All right, and this is a little bit more about the tumor suppressor genes. So it's basically describes a theory which is called a Knudson two-hit hypothesis, and that in different words expresses what I have already mentioned, in the sense that tumor is a recessive trait. So you actually need for both alleles of one specific tumor suppressor genes to be mutated to significantly increase the likelihood of developing cancer. And this can be demonstrated, for example, on patients with retinoblastoma, because normally these people are quite often heterozygous, but even being heterozygous increases the chance of getting the tumor later on, because these people, for them, it's enough to develop one somatic mutation on top of the hereditary one to develop the cancer that describes the loss of heterozygosity. Um, if people are homozygous, they are very likely to early on develop bilateral tumors, because these are related to tumors of the retina, as you may have gathered from the name retinoblastoma, although RB is present in a variety of other tumors. In this specific case, when talking about tumors of the retina, homozygosity means developing tumors quite early on, and the condition is very problematic. Before we move on to the next topic, I'm going to shift the Menti question to the next one, because we are going to be summarizing what we have partly covered and partly not covered yet. And we will be talking about the hallmark features of cancer cells. So the next question on Menti, I hope you can get there, is about thinking about some of the features that cancer cells are specific with compared to normal cells. So if you could throw in some words that you think would be important keywords for the hallmarks of cancer. Yep, it's looking very good. I'm getting invasion and metastasis, angiogenesis and proliferation, and these are all very valid points. A loss of differentiation, amazing. Invasion again, low metabolic requirement. Yeah, yeah, these are all great. So I'm gonna move on to the next slide. And you can see probably not all of the hallmarks, but the majority of the currently known hallmarks of cancer. You may have heard about this paper or these two papers, because they are really important papers summarizing the properties of cancers. There was one paper written initially in 2000, then there was another paper in 2011 where additional properties were added. So this is the more modern one, showing all the different properties. And as you can see, you have covered many of the very important things. So sustaining proliferation, there was replication, immortality. I'm not sure if anybody said that. Angiogenesis, definitely. But there's a few more. Oh yeah, deregulated cellular energetics. So you have actually mentioned that one as well. There is one specific concept as well related to this one, which is the Warburg effect. And that basically means that cancer cells will rely on glycolysis even if there is oxygen around. So probably related to the fact that quite often cancers, especially solid tumors, don't actually have as much oxygen around, because their uncontrolled growth leads to them increasing in size very quickly, and the angiogenesis cannot actually keep up all that well. So many of the cells rely on diffusion of the oxygen from quite remote places. And because, as I said, the cancer grows really quickly, the oxygen cannot actually get there perfectly. So that means the cells will then have to rely on anaerobic metabolism. But quite interestingly, this feature is then carried over even to the cells which would have better access to oxygen. So that's just one thing that can also be a good keyword for some of the essays. And then some things that people didn't quite mention as well. So avoiding immune destruction. That is actually one of the key features of cancer cells as well. And it's causing quite a lot of trouble with cancer therapy now, because as we will talk about in a little bit, one of the and probably the most rapidly growing field of cancer therapy is immunotherapy. And with the most modern immunotherapies, what we're trying to do is promote the patient's own immune system to target the cancer cells. And it seems that in many of these situations, the major problem is the cancer cells being able to deregulate some of the receptors that would normally be recognized, the cancer cells being able to release some cytokines that would block the immune response from happening. So avoiding immune destruction is also a very important one. So this can be a really good paper in general to read through to have a good summary of all the cancer cell properties. Stem cells are also one important concept to mention about cancer, because again, contrary to the popular belief that all cancer cells can grow completely, in an uncontrolled fashion. It's the case that only some of the cancer cells, and it's a relatively small subset, are the undifferentiated ones, which are actually capable of unlimited self renewal. Unfortunately, these are quite often enough for the tumor to grow in the way that we wouldn't like for it to grow. Um, and it's also quite important to be aware of this, because obviously if we want to eradicate the tumor completely, we want to be eradicating these stem cells. But it's not the case that all of the tumor cells would be stem cells and all of the tumor cells would be capable of this. And unfortunately, although I said we are trying to target them, they are again currently one of the big problems with therapy. They are a big cause of relapse after chemotherapy because they just stay there. We are not able to eradicate all of them, and unfortunately, they can cause a relatively rapid regrowth. All right, one more Menti question. That's maybe going to be one more later as well. So the next one, before we start the next topic, do people know which virus is sort of the main contributing factor to Kaposi's sarcoma? Interesting. We are getting quite a variety here. We are seeing almost all the different possible answers. I'm going to wait just for a little bit more because I think this one is a little bit harder. So not everybody has replied yet, or not everybody. There's quite a few people who have not replied yet, so I'm going to wait for a little bit more. All right. So we've got some HPV, some Hep C, some EBV, and a little bit more of HHV, and that one's actually correct. Let me move this. So it's actually human herpes virus 8 that's causing Kaposi's sarcoma. It's a sarcoma, Kaposi's carcinoma. It's a carcinoma in the mouth. Um, and this is just a summary of some of the tumors you will probably be hearing more about in association with oncoviruses. The mechanisms by which the viruses cause the tumors to develop can be slightly different. I think I've got one example there later on, and you can definitely do more reading on some of the other ones. So there's quite a few mechanisms. These are probably the best known ones. Probably the best known one overall is the human papillomavirus, and the squamous cell carcinoma potentially, um, in the context of cervical cancer. You may know that we are now being really, really successful at preventing squamous cell carcinoma with the Gardasil vaccine. So it's actually been able to reduce death from cervical cancer by about 1,000 to 4,000 cases a year, which is pretty remarkable. So that's really good thing we are doing. But there are other tumors that we unfortunately cannot or have not been able to find in the same way. You can read up on these a little bit more. Um, in general, the oncoviruses were discovered by studying the Rous sarcoma virus, um, and that's actually a chicken virus. And it was discovered by injecting cell-free extracts of the chicken tumors into healthy chickens. And it was shown that these chickens then developed cancer, unfortunately. Um, and it was later investigated more. It was discovered that this virus is actually a retrovirus which can incorporate oncogenes into the host genome using reverse transcriptase. Um, that one is not of that much interest in humans and at the moment, and one that is of much more interest is the HPV, as I have mentioned. And this is why for this one, I'm just going to briefly mention how this virus can cause the cancer to develop. So there are several types of the human papillomavirus. There's actually much more than these two. So you can see the most problematic ones in the cervical cancer are the HPV 16 and 18. but there are many more, and some of the other strains are relatively benign in the sense that they can promote development of common warts, but they wouldn't really promote development of a malignant cancer. But in this case of HPV 16 and 18, what they do is they produce oncogenes E6 and E7, and each one of them interacts with a different tumor suppressor gene. So E6 prevents P53 from promoting apoptosis. And similarly, E7 inhibits the retinoblastoma tumor suppressor gene in a similar way. So this leads to uncontrolled growth of the cells in the transformation zone of the cervix, and leads to development of the carcinoma. But then obviously if you are vaccinated and you are not infected with the virus in the first place, this is very unlikely to happen on its own in the cervix. So this is about the oncoviruses, and let's move on to management quickly. So this is just a summary of some of the managements. These are the major managements we've been using, at least to an extent. The reason the surgery and the chemotherapy are circled is because although there's loads of research going on in various other fields, surgery and chemotherapy are still the most used ones, the most evidenced ones. For some of the tumors, it would be radiotherapy as well. But these are still the largest ones. Having said that, the current trend in cancer management in general, as I have already suggested previously, is that we are trying to turn to immunotherapy, because obviously it has the big benefit of potentially being able to activate the person's own immune system to help the person's own immune system target the cancer cells, which is done in a very specific way, so it doesn't have the negative features of chemotherapy targeting basically all the cells in the body. So that's one of the most prominent benefits, and what's more, it could be, if done well, it could be much more efficient at actually eradicating the cancer cells. There are obviously some problems with it. So one of the problems, we have talked a lot about how cancer cells are quite problematic in the sense that their expression of proteins, of receptors and everything is quite deregulated, which also makes it quite difficult to find the perfect sort of feature of the cancer cells that can be targeted by T and B cells. But that's where the research is currently going and what the research is trying to get sorted. So just quickly about chemotherapy, the main aim is to reduce the size or potentially in some cases to eradicate the tumor. And it can be split into three main sort of pathways. The first one is neoadjuvant, which is before the planned surgery to just shrink the tumor and reduce the area of the tissue that will have to be cut out. Then adjuvant after surgery, and that's very important, especially if it's discovered in the surgery. Then with subsequent pathological analysis that not all of the tumor has been excised, and the margins were not clear of the cancer cells, which means there's still cancer cells in the body, and particularly in those scenarios, chemotherapy will help eradicate the remaining cells. Now, obviously, this is quite often the case that it was obvious before the surgery that unfortunately it wouldn't be possible to excise everything. So it's not like in the majority of cases you try to cut out everything and then you discover afterwards that it's not happening. But it's quite often the case, unfortunately, that we know that the cancer has spread already. But if the person is fit and well enough for the surgery, the best shot we have is doing the surgery and then adding chemotherapy to treat them. And the last option is using chemotherapy for palliation. So even when we know that the cancer will not be curable with chemotherapy, sometimes it can be very important to relieve some of the symptoms. So for example, for people who have quite extensive cancers in their throat, and are finding it very hard to swallow, speak, and those sorts of things, even if we know we might not be able to cut everything out and cure them, shrinking the tumors with some chemotherapy can be relatively useful. General principle, as you probably know, chemotherapy inhibits cell proliferation, but this is valid to any proliferating cells in the body. So chemotherapy is therefore not very specific and causes trouble in proliferating cells which are non-cancerous. So cells like especially hematopoietic stem cells. So all of your red blood cells and white blood cells can struggle. This is also why it's associated with hair loss, because the cells in the hair follicles cannot proliferate properly. It can cause relatively severe gastrointestinal side effects as well, because it targets the proliferating cells in the GI epithelium. And unfortunately, it can also cause some irreversible damage to the kidneys and to the nerves. However, if it's concluded that the benefits will outweigh these risks, it's still very often chosen. And there is a Menti question again. So just one quick Menti question about anti-metabolites, which is one of the classes of chemotherapy. We are getting some answers incoming. Lovely. I'm gonna wait for just a little bit more. It's quite funny to say we have some cancers incoming instead of answers in a cancer talk, right? Anyway. Let's see. All right, so we have a variety again, but the majority of people have got it right. The majority of people have said that it's 5-fluorouracil, and that's absolutely correct. So this is a summary of the main chemotherapy agents or main classes of chemotherapy agents used now. Anti-metabolites are the one inhibiting DNA synthesis through targeting synthesis of the individual bases. For 5-fluorouracil, it's affecting thymidine synthesis. For methotrexate, I think actually inhibits it inhibits synthesis of multiple of the bases through inhibiting tetrahydrofolate. So it just interferes with the synthesis of the bases necessary for DNA production. Alkylating agents, slightly similar in the sense that they inhibit DNA replication. They do it slightly differently though, because they don't inhibit the enzymes, but they cross-link with the DNA by attachment to guanine bases. And they interfere with forming of the whole DNA structure. And the last main class is microtubule poisons, which block mitosis because of inhibiting some of the microtubular function, which therefore blocks formation of the mitotic spindle. And in terms of some examples, you can definitely read it yourself, but you can see that for the alkylating agents, one of the big ones is cisplatin. It's very effective for not only testicular cancers, but it's quite commonly used for a variety of cancers as well. So that one's quite useful to remember. Vincristine, I think, potentially a little bit more old-fashioned, but it's still commonly used because, unfortunately, as I said, it's a common feature of all chemotherapy that they are very non-specific. So they are all old-fashioned in a way, but still worth using at times. However, sometimes resistance can develop against chemotherapy through a variety of pathways. It's slightly similar to you may have seen some of the bacteria talks, and resistance to antibiotics. In a slightly similar way, resistance can develop against chemotherapy. It can be via efflux pumps. It can be via decreased uptake of the drug. The drug targets can be altered. There's a variety of pathways through which resistance can develop, and this is why it's quite important to, even with chemotherapy, to use a combination of different types of therapy to reduce the resistance effects. And obviously, ideally, and again, hopefully in the future, we will be able to use combinations of less and less chemotherapy and more of the more specific therapeutic pathways. So targeted therapy in general, everything that's not chemotherapy, basically. Um, Now I'm not talking about surgery and radiotherapy. Those are relatively straightforward in the sense that you are targeting the tumor through localizing your therapy. Although radiotherapy can actually be general as well. But now I'm talking mainly about pharmacological target therapy. And the main ways of achieving this are hormonal therapy, small molecule inhibitors, and immunotherapy. And I'm just going to give you a few examples of each of these now. So in terms of hormonal therapy, there are a variety of types again. These are probably the best known and most used ones. Tamoxifen is very well known for antagonizing estrogen receptors in breast tissue, and it's very often used for treatment of breast cancer. However, it's got one disadvantage, and that is that it's actually an agonist of the estrogen receptors in the endometrium, interestingly. So we need to be mindful of the increased risk of endometrial cancer if we use tamoxifen to treat breast cancer. Again, sometimes the benefits may be larger than these risks, but it's something to think about. Aromatase inhibitors, these are quite commonly used in postmenopausal women because after menopause, the aromatase pathway is the main pathway of creating estrogen, which is why it becomes more relevant because when you block production of estrogen through this pathway, you can again treat breast cancer. And then the last major one is general testosterone reduction. So this, as you could probably figure, is most relevant in prostate cancer. It can be achieved through a variety of means. One of them is simply orchidectomy, because obviously if you remove the organ that is most involved in production of testosterone, you will reduce testosterone overall. Um, but it can also be done in a pharmacological way, so you can block release of luteinizing hormone, which is the main stimulator for testosterone production in the testes, or you can use anti-androgen, so directly target the testosterone itself. Small molecular inhibitors, there's quite a variety of them. One of the best known ones is that to tyrosine kinase that basically forms through fusion of two genes called the BCR and ABL. This is called the Philadelphia chromosome, and it's a very, very common feature of chronic myeloid leukemia. It's one of those leukemias that are more common in older age, and they are quite often associated with this fusion gene. And the main problem, therefore, is uncontrolled activity of this tyrosine kinase and promotion of cell growth. Which obviously means that if we are effectively able to target it, we can block the cell growth. And the small molecule that we can do this with is called imatinib, and it has actually achieved some very, very good results. And it can quite effectively help eradicate the disease early on. Unfortunately, it was discovered later that there is quite a lot of resistance. So later on in the disease, it stops being so effective and the cells keep proliferating again. So there can be quite a lot of disease recurrence. But it's still, at the time it was investigated, it was still a big improvement in the treatment of chronic myeloid leukemia because it helped improve the survival quite a lot. Um, Another one I've included because we have already talked about BRAF and the V600E mutation when we were talking about zebrafish melanoma. And this is just to show some success of an inhibitor of this mutated version of BRAF. This is actually from a phase 3 trial. So as the majority of you probably know, phase 3 trial is the sort of last compulsory stage of the drug development pipeline before the drug can be officially approved. There are phase 4 trials as well, but those can happen after the drug has been officially approved. And in this phase 3 trial, which involved 675 patients, groups were compared who received vemurafenib as the small molecular inhibitor and chemotherapy. And it was quite remarkable as the response rate in the vemurafenib group were actually almost 50%, whereas it was only about 5% for the standard chemotherapy called dacarbazine. Now, obviously, response rates can be a relatively vague term. In this case, it was assessed by changes in diameter of the lesions, but it can obviously assessed in a variety of ways. In the majority of these trials, it would be assessed by a variety of clinical criteria and some molecular criteria. On the right-hand side, you can see the impact on progression-free survival. So you can see that especially in the initial stages, after 2, 3, 4 months, vemurafenib was being really effective at preventing people from remission or progression of the disease. But unfortunately, as you can see, as it gets later along the disease towards 8, 9 months, unfortunately, there's a little bit of convergence with the two curves, and you can see that even vemurafenib is not able to prevent it, you know, in a much more long-term fashion. So these were small molecules, and now just briefly about immunotherapy as well. So these are the 4 main classes of immunotherapy investigated at the moment. The best known and best established are probably antibody-based therapies, so monoclonal antibodies against a variety of targets. The next one that is relatively well investigated with some good drugs approved already are immune checkpoint inhibitors. You can see an example of that on the image above. So these are related to these are slightly different from the cell cycle checkpoints that I talked about before. They are related to checkpoints on T cells, which can help prevent the T cells from triggering a cytotoxic response. And obviously, this is quite often a very useful feature of the T cells, because this is a way to prevent T cells from attacking our own self cells. But unfortunately, it seems to be the cause of the failure of immune system to respond to tumor cells as well. Some of these molecules are, for example, the PD-1 and the PDL1. That's the receptor and the ligand. You can see on the top. The other one you may have heard about is CTLA4. And they basically are receptors and ligands that, upon interaction between the T cell and the tumor cell or whatever other cell it is, inhibit the T cell from firing. So you can imagine, if we can block this interaction with the so-called immune checkpoint inhibitors, this inhibits the T cell and promotes the firing again. And the last 2 options of how we can use immunotherapy, at least in terms of the classes that we know up to date, is adoptive T cell transfer and cancer vaccines. Adoptive T cell transfer is based on collecting some leukocytes from the patient, and then sort of adjusting them in vivo and giving them back into the patient. So this has been done quite a lot with T cells, which can be collected, and then their receptors can be engineered to target some of the specific tumor markers. And they can then be a relatively effective way of targeting the cancer in the patients. And one last option are the cancer vaccines, which are based on basically injecting the patient with some components of the cancer. Again, could be proteins with some adjuvants. And what has been studied quite a lot recently is actually putting the cancer antigens into dendritic cells or other antigen presenting cells, and then injecting these into the patient. So the idea there is providing sort of the antigen as well as natural co-stimulation with the antigen presenting cell at the same time. So these are some of the newer developments, although these are at a stage where they still require a bit more research until they can become widespread therapy. So Herceptin I have briefly mentioned as an example of one of the antibody-based therapies. And I think it's probably the best known antibody-based therapy of cancer overall. And it takes advantage of the fact that many breast cancers express the receptor HER2, which is the human epithelial growth receptor 2. and Herceptin can block this receptor in those cells which actually do express it. And it's very, very effective in preventing the breast cancer from growing. Unfortunately, there's quite a lot of breast cancers that do not express this receptor. And if they also do not particularly well express other receptors, such as estrogen receptors, they are really, really hard to treat. So Herceptin, very good for some tumors, but unfortunately not in all patients. And this is up to molecular analysis of each of the individual tumors to see whether there's any point using Herceptin or not. Sorry. And this is just out of interest. Again, could be a study to include in some of your essays, or just out of interest to think about some of the most modern ways the cancer therapy has developed. And it's about the dendritic cell vaccines, which I have mentioned, and it's actually a phase 2 trial. So that is much smaller. I have mentioned the phase 3 trial, which involved almost 700 patients. As you can see, this one is much smaller. So it's not quite there yet. It's not quite at the approval stage yet, but it has achieved relatively good results. So it enrolled 19 patients with acute myeloid leukemia. And acute myeloid leukemia is unfortunately a disease that can respond to chemotherapy, but quite often it doesn't retain this response for very long, and people relapse after chemotherapy. I think the rate of people who stay in remission is less than 30%, and those are often young people or younger people, but because AML is a disease that affects old people quite often, we don't have a particularly effective way. Anyway, 19 patients were involved in this clinical trial. 17 actually underwent at least one cycle of the vaccination as was planned, and 12 out of these 17 patients remained in remission with a median follow-up of 57 months. So you can notice it's quite remarkable, because when I was talking about the vemurafenib, we were talking about 2 months, 3 months, 8 months, but now we're talking about 57 months. So you can see it looks like some of these cancer vaccine approaches will be able to really make a much more long-term difference. And quite surprisingly, they are also quite well tolerated. So some of you may be thinking, so if we boost the immune system like that, are we not going to cause some autoimmune disease? But it looks like if we do it well, and if we actually target the right cancer components, like we did in this case, sorry, I didn't actually say at the beginning, you may have read it, but this was actually done by fusing dendritic cells with cells of the leukemia, both from the patient. So obviously that has the major benefit of presenting a lot of the different leukemia antigens on the surface of the fused dendritic cell. So it seems like we were able to actually just generate a vaccine that targets the leukemia cells rather than greater proportion cells in the body. So it was much better tolerated than one would think that it could be. So these are all the main things from me. Feel free to get in touch if you have any questions, and feel free to ask any questions now. I hope it helped a little bit at least. I hope it gave you a nice summary, and I hope it gave you some ideas of some of the studies and research that you could be presenting in your essays as well. And please do give me some feedback by clicking on this, or you can actually click on the link probably, but you can use the QR code to give me some feedback. That would be really, really helpful. And it will make me and everybody from OSME much more keen to send you the slides as well if you give us feedback. So thank you very much. I'm going to hang around for a little bit longer if anybody has any questions. Yeah, there's a question if I have the link. Let me see if I can copy it into the chat. I should be able to copy it into the chat.
Oh, sure. Somebody is asking if I can explain the difference between neoplasia, hyperplasia, and hypertrophy. Okay, so hyperplasia and hypertrophy um differ in the sense that one of them include is mainly about proliferation, and one of them is about growth in the size of cells. Um, Let me quickly check. I think hyperplasia is the one about proliferation, and hypertrophy is about general growth in the size of the cells. And then neoplasia is specifically associated with the tumor proliferation and growth due to the fact that the cells obtain new properties on top of just growing and proliferating. Um, so these would be the main differences. Let me just quickly check. I'm not saying it the wrong way around though with hyperplasia and hypertrophy. Yeah, so yeah, I was saying correctly. So hyperplasia is the one which is more about proliferation, and hypertrophy is the one that's more about growth in size. No worries.